but please feel free to ask your questions in French. We will give you more guidelines a bit later. And I did my slides in French, so if you're not really comfortable with English, then you can follow with the slides. And I will be starting by saying a few words about our network. So my name is Bernard Srour. I'm the coordinator of the WebiNACRe network, which is the French Network for Nutrition and Cancer Research. We have 4 main objectives: to develop and to federate multidisciplinary and collaborative research on nutrition, physical activity, and cancer. We also organize and participate to collective expertise. We have also a mission of training of healthcare professionals and of information to the lay public and to the patients. We, our missions, or we do have a role before the diagnosis of cancer, so in primary prevention, but also in cancer management, in nutritional cancer management, and in tertiary prevention, so in the prevention of second cancers, or in the improvement of quality of life, or the improvement of survival, etc. So the network is now exists now since more than 22 years, and we're implemented almost in the full French mainland territory. And our teams and experts cover several disciplines of research in nutrition and cancer, from epidemiology to clinical research, experimental research, and social and human sciences. We are soon getting expanded to other European countries, and we are going to be founding a European club in nutrition and cancer research that you will be soon hearing about. Just a few words about our network. So we gather more than 400 experts in France, and more than 170 research projects, among which 1/3 are collaborative research projects, so that involve at least 2 of our teams. We organize and participate to regular scientific meetings, among which the meeting of today. We also, as I was saying, participate in the training of healthcare professionals and organizing meetings and events to the lay public and the patients. We also have a certified website for the patients and the journalists to get validated information on nutrition and cancer, and also other tools for scientists, healthcare professionals, patients, and the other lay public. WebiNACRe is our new trimestral scientific meeting. It's 100% online, free, and accessible to everyone. We will be having French-speaking or English-speaking experts from France or anywhere else in the world, talking about nutrition, physical activity, and cancer, covering several disciplines, such as public health, clinical research, experimental research, or social and human sciences. And participants would be having the chance and the opportunity to discuss with our expert once the presentation is over. All these webinars would be available on replay as soon as the webinar comes to an end. So today is our second webinar, and we have already had our first one 2 months ago about the Nutri-Score, this front of package labeling with Mathilde Touvier, and you can still access it and watch it online on YouTube or on our website if you're interested. So welcome to everyone, and thank you all for joining. Just a small guideline for your questions. There's a button called Q&A, questions and answers, questions et réponses pour les francophones. So please, we would kindly ask you to provide your questions and answers through the Q&A section and not in the chat section. Our expert has no problem answering or trying to answer your questions in French. So if you would like to ask your questions in French rather than in English, please go ahead. Si vous voulez poser vos questions en français, n'hésitez pas. Notre intervenante parle même bien français et serait prête à faire un effort pour vous répondre en français ou en anglais, mais en tout cas, on essaiera de faire les interprètes. So I will start by presenting our moderator for today, Professor Stéphane Servet, who is a tenured professor at the Université de Tours and a visiting professor at the University of Alberta, and he is also a member of our NACRE network. Stéphane.
Merci Bernard pour cette présentation. Donc, bonjour à tous et à toutes. Moi, je vais le faire en français, hein. Ça va être plus simple. Je suis désolé pour les anglophones. Je voulais remercier d'abord le professeur Baracos parce que quand on a commencé à parler des WebiNACRe au sein du réseau NACRE, j'ai tout de suite pensé à elle, hein, j'étais sur place. Et je lui ai demandé si elle était d'accord pour participer et elle n'a pas hésité un seul instant, alors que je sais qu'elle est, très, très, très occupée. Donc, je la remercie beaucoup pour ça, pour avoir accepté de faire ce WebiNACRe. Je suis aussi honoré, hein, je vais le dire, de vous présenter le professeur Baracos maintenant, parce que pour ceux qui travaillent dans le domaine de la dénutrition induite par le cancer, de la cachexie cancéreuse, hein, c'est l'autre terme qui peut être utilisé, la sarcopénie, etc. Et bien effectivement, le professeur Baracos, c'est une chercheuse internationalement reconnue dans ce domaine. Voilà, c'est vraiment, vous avez vraiment une experte qui va vous faire une excellente présentation, comme je la connais. Alors, si je fais une petite biographie du professeur Baracos, alors elle a actuellement une chaire de médecine en soins palliatifs au département d'oncologie de l'Université d'Alberta. Et au cours de sa carrière, elle a toujours travaillé, la grande majorité de sa carrière, elle a travaillé sur la physiopathologie de l'atrophie du muscle squelettique, et toujours dans un effort d'approche fondamentale et de recherche translationnelle avec des recherches cliniques et toujours en relation, en ayant tissé un réseau de recherche internationale. Et elle a commencé à travailler sur l'atrophie musculaire induite par le cancer en 2003. Ses contributions à ce champ de recherche sont fortement significatives. Elle a fait beaucoup avancer le champ de recherche et elle a développé, entre autres, hein, elle est connue pour avoir développé l'utilisation des scanners pour l'analyse de la composition corporelle, hein, masse musculaire, masse grasse, etc., afin de suivre l'évolution de la composition corporelle et entre autres la sarcopénie. Donc, après cette petite introduction, je vais laisser la parole au professeur Baracos et je vous rappelle donc que pour poser les questions, il faut bien prendre l'onglet questions et réponses et que vous pouvez poser les questions en français ou en anglais, ça ne posera aucun souci. Merci beaucoup en tout cas à tous de nous avoir rejoints. À toi, Vickie.
Ok, je commence. Vous voyez mon écran. Bonjour à tous et toutes from Canada. I'm Vickie Baracos. I'm a cancer researcher in Edmonton, Canada. And I have perhaps the distinguishing characteristic of having spent the first half of my career in a university department of nutrition. And thereafter, the second half of my career, and that would be since 2003, in a university department of oncology with efforts devoted to questions related to nutrition and cancer. So I'm very happy to come to you from Canada today, and I hope to, in future, join your group for other discussions. My title today is about the existence of anabolic resistance in patients with cancer. And that's a question, not a statement. So I'm going to start out with a discussion of concepts, questions, and evidence on this point. And the first thing I'm going to point out is that this is a discourse that is somewhat musculocentric. And that's because muscle is a large organ with a physiological, metabolic, and nutritional importance, which is extremely large. And it fits into nutrition because of the size of the muscle organ. We actually have nutritional requirements that are in part dictated or defined by those nutrients that are essential for the repair and anabolism and maintenance of muscle. On the other hand, when we are deficient of nutrients, muscle becomes a source of nutrients, breaks down and contributes amino acids systemically to be used by other organs. So that's why muscle is at the center. So when we go on to consider muscle in the context of cancer, we have some kind of diagrammatic, and I'll point out that this is a cartoon, and it's a cartoon that has predominating the tumor's interaction with the immune system. And those factors together are responsible for the generation of tumor and inflammatory derived molecular actors, which are numerous. And those molecular actors have for their effect to perturb all of metabolism. So we consider muscle to be at the center of this metabolic disorder because muscle is wasting. It is continuously wasting. It is continuously lost. It is severely depleted. And that depletion is associated with morbidity and mortality of every type. It's important to recognize the complexity of a situation wherein it's not just the metabolism of muscle which is modified. So adipose tissue, endocrine system, central nervous system, behavior, all of these things are profoundly changed, and all of them conspire to activate and perpetuate the wasting of the muscle. Now, in consideration of all of this, it strikes me that this is a very pertinent question, which has been on my mind for a long time. So please consider this question. Consider your opinion as to whether it's true or false. And please also consider on what basis you would attest that it is true or false. Let me speak to the plausibility. And this is a statement I encounter every day in my oncology department. We have people who are physically inactive, possibly very deconditioned. They are old on average, and some of them very old. They are often chronically malnourished, chronically inflamed, being treated with a variety of chemicals that could modify anabolism. They have cancer, sometimes of advanced stage, and because of their age, are typically polymorbid. So really, do you expect that they have a capacity for anabolism? Because of my two worlds of scholarly activity, I've had a chance to ask this question of a lot of people, not by an international survey, but by a show of hands. And I can attest to you that if I ask that question to a room full of oncology healthcare professionals, the majority opinion is that that is a true statement. They may suggest some exceptions, but certainly the majority position is that the statement is true. Whereas if I ask this question to a room full of nutrition professionals, their majority belief is that this is a false statement. So what's really important about that is if you believe that it's a true statement, your clinical course of action is very simple. What should you do? Nothing. So it is a key question to resolve. And I would put it to you that neither of these polar opinions are likely to be right. And then what really matters is the evidence that we may have to bear on this question that is applicable to different subsets of our patient populations. You can see this polarization, and this is my point related to the evidence. The evidence on this question is little and of low quality. And it's subject to very diverse interpretations. So now I'm going to compare and contrast to you some guidelines, two guidelines, and these two guidelines are really polar opposites. These two guidelines consider the same evidence, not different evidence. They're all reviewing and accessing the same information. So if you look to the nutritionist guidelines on nutrition in cancer patients, they have a guideline which is 37 pages long and considers all evidence, including weak evidence, moderately strong evidence, and strong evidence. And based on that, they can come up with 43 recommendations, albeit that they qualify when a recommendation is based on weak evidence, they say so, and also suggest areas for future research. Please contrast this with the guideline of the American Society of Clinical Oncology, which does not admit any evidence of any kind except randomized controlled trials with at least 20 participants. So when they have set a barrier of rigor of the evidence that high, they are only able to produce 2 recommendations. So what we need to consider here is the evidence that is suggestive about anabolic potential and try to understand where we do need to know to do more research. So in my second part, I'm going to be talking about protein anabolism specifically and metabolic studies or inquiries in human subjects designed to understand that. So the basic premise is this: muscle protein turns over all day and all of the time through the inverse processes of synthesis and breakdown. And that synthesis and breakdown is to a very large extent driven by meals, during which the biosynthetic rate goes up very strongly. The degradative rate falls, leading to net anabolism. During the interval, the post-absorptive or fasted state, degradation rises up, synthesis falls down very low. So then we have net mobilization of protein from muscle and amino acids leave the tissue. So this is to a very great extent about optimizing these feeding related responses. So one of the first things we learned about these feeding related spikes in protein synthesis is that they are specifically augmented by branched chain amino acids. So that's leucine. It does that via its metabolite beta-hydroxy beta-methylbutyrate. These are features also attributed to the other branched chain amino acids, valine and isoleucine. Simple story made short. If you take a casein protein, which is not rich in branched chain amino acids, there is a biosynthetic response to feeding, but it's small compared to the biosynthetic response with other proteins that are relatively leucine and branched chain amino acid rich, particularly the whey protein, which gives a large anabolic response. So this response to feeding has been much studied. It's been studied in young people, healthy people, and also in performance athletes. And what they have done with this response is optimize it. So many research investigations to define the quantity of protein, the type of protein, the specific amino acid composition, the timing of the intervention, as well as the nutrient mixture, so other nutrients of other types, which can help maximize this response. And then that science has moved into conditions where people have difficulty maintaining muscle mass. So here's a sample of an example for you of studies that have been conducted on this theme in older people. So I select these investigations as examples because they were randomized studies. So they're good quality investigations. And you'll see here again, whey protein, leucine enriched whey protein, branched chain amino acids is the theme of the optimized nutritional support. And the subjects are healthy older people, sarcopenic older people, old people with and without exercise, and so forth. And what I would like to point out about these papers, and hope that you will take the time to read them, is they support the notion that older people are able to produce robust anabolic responses. However, what we perhaps want to know, and while that is encouraging, we want to know whether this is true of patients with cancer, for which we have really now on this type of metabolic study, only 3 reports. But I would like to point out to you that these reports that are available show no evidence for anabolic resistance. So these studies are few because they're difficult to participate in. So these studies require that a patient with cancer who is elderly and perhaps ill go to a metabolic unit, stay there for many hours, be punctured for infusion and sampling. So it's not trivial to gain participation in such studies. But first, read the titles. Habitual myofibrillar protein synthesis is normal in patients with gastrointestinal cancer. Normal protein anabolic response to hyperaminoacidemia in insulin-resistant patients with lung cancer cachexia. Muscle protein synthesis in cancer patients can be stimulated with a specially formulated medical food. Now I'll share you some details of these 2 last papers. So the study from Stephanie Chevalier's group is a isotope kinetic study with carbon-13 labeled leucine, and the anabolic response is elicited by hyperaminoacidemia achieved by infusion of insulin and amino acid mixtures. It's a real metabolic study. What I want to point out to you about the patients in this study is they have advanced stage non-small cell lung cancer, even metastatic stage 4 disease. They have lost 9% of their body weight in the last year. They're documented to be insulin resistant for glucose uptake. And they are inflamed by significantly, compared to the healthy control matched group, by multiple different criteria. So on the surface, these do not look like candidates for anabolism. So they participate in a very complex study with starting out in a basal, this means fasted state, and they go on to receive an amino acid infusion with insulin, and they go on further to receive a higher level of amino acid infusion with insulin. So this is a complex stepwise metabolic study with blood sampling and measurements over time. So what I want to take you to is their findings. And this is the net protein balance. So this is the difference between synthesis and breakdown. Now in the basal state, I mean the fasted state, net protein balance is of course negative, and very similar in the healthy controls and the lung cancer patients. At the first step of amino acid and insulin infusion, net protein balance becomes positive, and the effect is actually larger significantly larger in the healthy controls. However, when we move to a higher amino acid infusion rate, which is equal to about 25 grams of total protein, we have a robust response, which is very strong and not different between the healthy controls and the cancer patients. So that gives you evidence, at least at higher amino acid infusion, that anabolism is perfectly possible. Now, here's another metabolic study, in this case done by Nicholas Deutz's group. This is now a bit different. These are metabolic studies of muscle protein, fractional synthetic rates. Everybody in this study has cancer. And these are the comparators. On the one hand, the measurements have been made during fasting and then during provision of a normal oral nutritional supplement containing 25 grams of casein, an ordinary protein. On the other hand, the nutritional treatment is a composite nutrition treatment with a high dose of a high essential amino acid protein plus additional leucine, as well as other nutrients designed to potentiate that response. What do we find out? That the experimental and control groups are not different in their muscle biosynthetic rate during the post-absorptive state. In the fed state, it is only this nutritional food which activates muscle protein synthesis robustly in the patients with cancer. So only they experience a net positive increase in muscle protein balance during feeding. This is also promising of the potential of a powerful or concentrated and complex nutritional support to activate protein synthesis in muscle acutely. What this will give over time with constant feeding of such a diet is currently unknown. And that's why I am very positively and hopefully waiting for the outcome of this clinical trial. So I'll point out to you that this is an international phase 3 randomized study with 240 participants, which is now closed to accrual and will probably publish its report in 2002. This looks a lot in terms of its design like the study I just described to you, but it's feeding over 6 weeks. So first, on the one hand, we have for the comparator arm, usual care, including usual nutritional care for patients with non-small cell lung cancer or pancreatic cancer. And then we have a specialized high protein, branched chain amino acid rich, and also omega-3 fatty acid supplemented oral nutritional support, combined with individualized dietary consultation, personalized physical therapy, and non-steroidal anti-inflammatory therapy to try and cool off some of that inflammation. So we will learn the outcome of this study over 6 weeks of feeding, particularly whether muscle mass determined by computed tomography will show a robust activation and gain of muscle mass. We have very few phase 3 studies in this space, so I'm optimistic and hopeful to see the results of this study, whatever they may be. So now I'm going to move over to a different line of evidence, which provides some form of evidence for muscle gain or loss at an individual basis. And this is using the diagnostic images that are acquired for routine cancer care. So our patients are imaged to diagnose their cancer, to follow their cancer, and we can extract highly precise, very specific measurements of muscle, what muscle is doing over time from these same measures. Now, about the measurements, I would like to say these measurements have been around for more than a dozen years. And I'd also like to say that probably in literature at this time, more than 200,000 patients with cancer have been characterized using these methods. So that's my sum total of participants in the literature, which already exists. So a method which is being much used. I would underscore that it has a convention, and the convention is to extract a single axial lumbar image at the third lumbar vertebral level, and to use that as a substrate to compare people with each other and to compare people over time. The short story on that is that this level was chosen because the area of these abdominal and paraspinal muscles at this level is highly proportioned to whole body muscle mass. So just want to remind you of what these measurements are, and then take you forward to discuss the possibility, and in many studies, to now look at people over time. So these are some images from a study by Sami Antun, just to point out to you that you can take a patient who has not yet started a cancer treatment and look at them again 6 months later, 1 year later, and use these precise and specific measurements to clock what their muscle mass is doing over time. Now, I'm going to now take you into two very specific studies where that was done. So I'm going to be talking about muscle measurement called muscle change, and the units of muscle change are square centimeters. Okay. And this has been done in, for example, a population of people with locally advanced cervical cancer. So this is not a curative intent treatment setting. And there's a fairly aggressive therapy in this paper. This is concomitant treatment with cisplatin plus radiotherapy followed by brachytherapy during 4 months. So the muscle change is between two scanners before the treatment plan and after the treatment plan, representing how muscle changed over time. So on the left, what is represented is the fact that most people's muscle change has a negative sign, which means muscle is being lost to a mild degree, a moderate degree, or a very severe degree. But importantly, some of the people, and in this study, about 25% of them, gained or maintained muscle during this treatment plan. Now, here's another representation of the same data. And this time I'm putting two axes in front of you. So we have loss and gain of muscle on the horizontal, loss and gain of fat on the vertical axis. So again, I'd like to point out to you that in this advanced cancer population and a highly aggressive treatment plan, we do have people who gain both muscle and fat so that they are globally anabolic. So in a recent time in 2021, Lorena Arribas published a very similar study to the preceding one, head and neck oncology, sick people, generally malnourished, and receiving aggressive treatment. So this is induction chemotherapy followed by concurrent chemoradiotherapy, and the chemotherapy again contains cisplatin or carboplatin. It's cytotoxic and has many side effects. So once again, I've taken Dr. Arribas's data and displayed it in this unique way, showing her population distribution of muscle change over time. Not unexpectedly, there's muscle loss of a moderate to large degree in this sample, yet some individuals, 20% of this population, go through this treatment plan to gain muscle, and indeed, again, this representation showing you that a subset of this population gains both muscle and adipose tissue for a net anabolic state. So the reason I'm emphasizing this is I think this is an opportunity to go forward to do many different kinds of studies. So unlike the metabolic study with the infusions, everybody can do this. And they can do it on images already acquired in routine care. So you can detect gain or loss of muscle without asking your patient for any test or participation that they have not already done. So you could formulate an idea about an intervention that would move people from this group towards this group, or from this space into this box, and detect this as the primary outcome of your intervention. So these results make me hopeful for two reasons. One, they give you these two studies give you evidence of anabolism actually happening in people in the worst possible situation for anabolism. And they also give you a method to do further research to test the efficacy of different interventions, which is low burden. So I'm optimistic, but I'm also circumspect. So my last theme to finish this presentation is about the challenges. And these are the catabolic drivers generated in the tumor-bearing state and the side effects of chemotherapy. Both of these things have a huge potential to limit our ability to deliver a robust anabolic response in different patients to different degrees. So we need to understand this, and we need strategies to manage it. So I'm going back to my pathophysiological diagram just to remind you that we have in the physiological state and induced by a tumor, we have a tremendous number of catabolic and anti-anabolic actor molecules. And in 2018, when I drew this cartoon and published this article, this was the list. In the meantime, we have discovered even more new, previously unknown catabolic actor molecules that augment this already complex mixture. Another thing that we have discovered is that many cancer treatments, specifically anthracyclines, fluoropyrimidines, platins, camptothecans, and tyrosine kinase inhibitors, could be described as catabolic actor molecules that group functionally with these other types of molecules. And that I'm going to blow up for you a little bit by discussing first that this appears clinically. So we've been learning about this for the last decade, starting with this report from a placebo-controlled study, which identified that sorafenib, compared to placebo, induces great weight loss and specifically significant muscle loss. And this study was also prominent in a high impact factor clinical oncology journal, showing that during systemic treatment for colon cancer, using different kinds of first-line regimens for that disease, we have subsets with minor muscle loss, moderate muscle loss, and severe muscle loss, where severe muscle loss corresponds to greater than 9 percentage points of muscle loss during the treatment plan, also corresponds to higher mortality, so a poor prognosis. So we know that cancer treatment induces muscle loss and has a poor consequence. It's evident clinically. And then in another corner, the biologists have been digging down on how all of these factors and effectors influence the muscle cell directly. So to go back, so now we have a muscle cell, and we have learned that these tumor-derived and inflammation-derived molecules act on muscle cells via receptors. And via those receptors, they activate a series of transcription factors that go on to induce a whole atrophy transcription program that has for its effect destruction of myofibrils. So the biologists most recently have now established for us the mechanistic basis of the systemic treatment effects. So these cancer treatments that are designed to inhibit proliferative pathways in tumor cells, not surprisingly, significantly inhibit proliferative pathways in muscle cells. Also, at least 6 types of cytotoxic chemotherapies enter muscle cells, activate all of the catabolic transcription factors that ultimately result in the disruption and destruction of myofibrils. So these influences are the detriments to our ability to exploit the anabolic potential that our patients may have. So what we need is a focused effort to understand how we may modify or mitigate these effects. So here I would conclude with what makes me optimistic and what makes me reserved. I think it's remarkable that given the state of some of the patients I've showed you with advanced stage cancer, highly aggressive treatments, indeed, we do have proof in principle that net muscle anabolism does occur in some patients based on radiological evidence. And based on metabolic evidence, there is a normal anabolic response to branch chain amino acid enriched protein supplements of different types. So these things exist. I believe we could stand to optimize them. Yet what we're going to have to deal with is an overall deficit of evidence, the quality of evidence. We need recipes to optimize anabolic responses in patients with cancer. So this would be dose, amino acid mixture, timing to anabolic windows, and specialized for different cancer treatment regimens. And then finally, we must find a way to manage the catabolic drive and side effects of therapy. And when we do that, we will open all of the anabolic windows possible for our patients. Thank you so much, and I'm ready to answer your questions.
Merci, professeur Baracos, pour cette superbe et très intéressante présentation. Donc, les questions sont ouvertes. Je rappelle en français, en anglais, vous pouvez les faire en écrit. Et comme il a été dit, si vous avez des questions que vous voulez poser à l'oral, c'est sur le 1, il faut lever la main.
J'ai une question dans le chat où j'ai Christine qui a levé la main. Donc, je vais donner la parole à Christine Bobin.
Hello, thank you so much, Vickie, for your presentation. J'avais une question. You show us beautiful data about the interaction between chemotherapy, antimetabolites, and also other drugs with les cascades de signalisation. What about the interaction between immunotherapy and muscle atrophy?
It's the least studied area. So we have many fewer reports on immunotherapy, either from the image-based approach or actually the underlying biology. So at this point in time, if you are asking about any investigation where someone used an immunotherapy and tried to test these interactions, I do not believe that has yet been done. And I think yours is an extremely important question because the therapeutic plans are moving and they're always moving. And let's say, just for purposes of discussion, that these effects, treatment effects, are very specific. So it may be that you can rescue anabolism in people treated with 5-fluorouracil with one recipe, but you need to rescue anabolism from, I don't know, nivolumab with a different recipe. We do not know this. Au pire, ce sera une question de thérapie optimisée selon chaque molécule thérapeutique ou regimen, treatment plan, I mean. So, where a real, une thérapie, c'est pas forcément un médicament, c'est gemcitabine plus fluorouracil ou paclitaxel ou irinotecan plus fluorouracil. La complexité de la chimiothérapie, c'est assez importante et on n'a pas d'informations par quelle voie on optimise la protéosynthèse selon les catégories thérapeutiques.
Merci beaucoup.
Professeur Baracos, pouvez-vous voir les questions qui sont posées par écrit ou pas?
Si la metformine peut-elle contribuer à la réduction de la masse musculaire? Aussi une bonne question. Pour l'instant, sans information, la seule chose que je pourrais contribuer à cette question, je sais qu'une étude aux États-Unis chez les patients traités pour le cancer du côlon avec metformine, l'étude a été abandonnée pour la raison que les patients en avaient marre des effets secondaires gastro-intestinaux et ils n'ont pas voulu continuer l'étude avec la metformine parce que ça entraînait les symptômes gastro-intestinaux. There's also a question from Alice and about exactly who were the patients. So we go back here. C'est une question très pertinente dans ce continuum de gain ou perte de muscle. Qui exactement avait gagné du muscle et est-ce que c'était attribuable à leur activité physique ou bien nutrition ou autre chose? Dans cette étude, il n'y a pas de données. Madame Arribas avait fait son mieux pour imaginer les facteurs contribuant au gain et inversement à la perte de masse musculaire. Et elle a trouvé que les perdeurs avaient plus d'effets secondaires, des toxicités de leur chimiothérapie, comme nausées, vomissements, douleurs dans la bouche, etc., plaies dans la bouche. Alors, ils étaient plutôt symptomatiques et ça correspondait à une quantité de perte plus importante. Mais votre question, en fait, c'est la bonne question. Et si c'était possible en prospective de capter les données pour mieux comprendre qui sont les répondeurs et si c'était la réponse correspondait à leur nutrition, symptômes, plusieurs autres choses. On aura la possibilité de dévoiler l'identité des répondeurs dans ce contexte. Pardonnez mon très mauvais français.
Il est très bien et je crois que tout le monde a compris ce que vous avez voulu dire. Stéphane, il y a une question dans le chat.
Oui, j'ai vu, ouais. Merci Vickie. Il y a une question qui vient de Belgique, de Jean-Paul Thyssen, que tu dois connaître. Alors, il demande en fait quelle est la relation entre la masse musculaire et la masse grasse, hein, en référence au papier de DAS il y a quelques temps. Est-ce que le gain de masse grasse est nécessaire pour gagner du muscle et comment il est possible de faire gagner plutôt du muscle plutôt que du gras?
Ça, c'est une très bonne question. Aussi une question qui vaut de la nouvelle recherche. L'étude de DAS était une étude expérimentale où ils avaient manipulé l'habilité, la lipolyse. Et si la lipolyse était bloquée, la perte de masse musculaire semblait impossible. Et c'est une étude faite avec des knock-out ou knock-in, donc définitive. Mais dans le théâtre clinique, on n'en sait rien du tout. En fait, fascinant aspect des data dans ce genre d'études, vous avez ceux qui avaient perdu muscle et tissu adipeux, ceux qui avaient gagné du tissu adipeux en perdant du muscle, gagner les deux et quelque peu, je dirais, pas beaucoup de cas dans les circonstances où vous avez gagné un peu de muscle en gagnant du tissu, gagner du muscle en perdant du tissu adipeux. Et on n'a pas d'explication pour l'instant de cette diversité de comportements. En réponse à la question posée par Fabio Ferro,
Which is the part of this lost muscle is linked or caused by systemic inflammation in cachexia, TNF-alpha, IL-6 or IL-1?
So, la question, il y a une salade d'acteurs métaboliques pro-inflammatoires dans la famille tumor necrosis factor. Il y a TNF-alpha et tweak. Dans l'interleukin-6 family, vous avez interleukin-6 et LIF. Et bien, dans this is the TGF-beta family, activins, myostatin et TGF-beta. Et il manque horriblement les enquêtes où les chercheurs avaient cherché les profils des facteurs pro-inflammatoires et plus largement tous les facteurs potentiellement coupables du catabolisme musculaire. Très peu d'études cliniques où les chercheurs avaient essayé de chercher le profil de tous les facteurs. On ne sait, pour commencer, quel est le profil individuel. Il peut exister des patients qui ont un profil plutôt TGF-bêta ou plutôt interleukin, quoi que ce soit, ou autre chose. On n'a pas cette information et nous n'avons pas pour l'instant des études où les patients avaient été administrés les inhibiteurs montrant un effet tel que anti-TNF, anti-IL-6, etc., qui pourrait donner une réponse définitive à cette question. Nous avons par contre une vague d'anticorps contre GDF-15 en development pour ce syndrome par, je ne sais pas, 4 ou 5 entreprises pharmaceutiques en phase 1 et phase 2, études cliniques pour ce problème. On verra bien, mais ce sera la première fois où on aura une une idée si un ou plusieurs de ces facteurs sont responsables du catabolisme présent dans une population de patients.
Merci Vickie. Si je peux rajouter un tout petit truc, c'est vrai qu'il y a toutes les études cliniques qui ont été faites pour essayer d'utiliser des anticorps anti-cytokines inflammatoires. Il n'y en a déjà pas beaucoup, mais ça n'a pas donné des résultats fabuleux.
Et les peu d'études dont tu parles, Dr. Retrouvez, sont de qualité et de conception de il y a 20 ans et vraiment de very poor studies. Je dirais, j'aurais tendance à dire que ces études étaient inconclusives, ni positives ni négatives, parce qu'ils avaient tant de limitations qu'ils étaient à la fin ininterprétables. Mais j'ai un fort espoir pour les études à venir.
Bernard, tu veux conclure?
Oui, je préfère conclure. On est presque arrivé à la fin. Je vais déjà remercier sincèrement le professeur Baracos de nous avoir donné cette chance de venir présenter dans ce webinaire. Merci beaucoup d'avoir accepté notre invitation. J'imagine que toutes les participantes et tous les participants sont partis avec un grand bagage scientifique qu'ils ont appris grâce à votre présentation. Merci beaucoup et on espère vous revoir soit en visio, soit même en présentiel lors de l'une de nos journées à Paris. Donc, on était vraiment très contents et très honorés de vous avoir, Vickie. Merci beaucoup.
Si vous avez des arrière-pensées, des questions, cherchez vickie.baracos@ualberta.ca. Je répondrai aussitôt à la question et la discussion. Merci beaucoup.
C'est noté, merci beaucoup. Et Stéphane également, merci beaucoup d'avoir fait le relais avec Vickie, de l'avoir invité, mais aussi d'avoir modéré très habilement ce webinaire. Merci beaucoup aussi pour ton expertise. Et avant de conclure, donc, je voudrais dévoiler donc, notre expert du prochain webinaire qui aura lieu donc, le 22 septembre 2022, de 13h à 14h, heure de Paris. Donc là, on va avoir plutôt une experte psychologue sociale de la santé, Madame le professeur Marie Préau de l'Université de Lyon, qui va nous parler donc de l'intérêt de l'approche des représentations sociales pour appréhender les comportements alimentaires et de santé dans le domaine nutrition et cancer. Donc, on vous attend nombreuses et nombreux également pour ce prochain webinaire. Et avant de clore, il me reste juste à vous remercier, la cellule de coordination du réseau NACRE, Julie, Charline et Juliette, et également à vous dire que ce webinaire sera bientôt disponible en replay sur YouTube et sur notre site web si vous êtes intéressé à regarder le replay. Voilà, bonne soirée, hydratez-vous bien et à très bientôt.
Au revoir. Nous, c'est bonne journée.
Bonne journée, bien sûr. Bonne journée aux Canadiens.